Interest. Today, we're very fortunate to have Dr. Ayoma Attygalle talking to us again. She's already taught on this course previously, and she recently also taught on the Pathological Society Winter School. So I think that we owe her a great debt of thanks. Dr. Attygalle is consultant histopathologist at Royal Marsden, which is one of the premier cancer hospitals in the UK, if not Europe. Her work specializes in gynae particularly endometrial cancer, and also in lymphoma. She's done an awful lot of work in the pathogenesis and biology of T follicular helper cells and refined that category in the WHO classification. So today she's going to talk to us about Hodgkin lymphoma and its mimics. Hodgkin lymphoma, quite a common lymphoma, and can often look like many other lymphomas and also reactive conditions. So very difficult, very easy to miss it or misinterpret it if you're not aware of these. So without taking any more of your time, Ayoma, over to yourself. Thank you.
Thank you, Richard. So the topic of today's talk, it's a case-based discussion, is Hodgkin lymphoma and mimics. So Hodgkin lymphoma historically, the entity that we called Hodgkin lymphoma, we now know are actually two distinct clinical pathological entities. The vast majority of these is the classic Hodgkin lymphoma, which accounts for 90% of all cases. And around 10% of these are nodular lymphocyte predominant Hodgkin lymphoma. Now, these are completely separate diseases. And actually, although the fifth edition of the WHO still retains the term nodular lymphocyte predominant Hodgkin lymphoma so as to avoid confusion, the international consensus classification, which is the other classification which came out in 2022, has actually changed the terminology to reflect this. And this is, in ICC terminology, this is nodular lymphocyte predominant B-cell lymphoma. So important to recognize that there are two distinct clinical pathological entities, and we'll go into that in a little more detail. So what do these two have in common, and why historically have they been lumped together? So both are node-based lymphomas, both are lymphomas that affect teenage and young adults, and they both are characterized by large atypical either mononucleate or multinucleate neoplastic cells that are surrounded by a variable mixture of non-neoplastic inflammatory cells. And these neoplastic cells are often rosetted by T cells. So these are the things that these lymphomas have in common. So if you look at the classic Hodgkin lymphoma, there's a bimodal distribution. So there you have the younger age group and a second peak later in life, whereas in nodular lymphocyte predominant Hodgkin lymphoma, although the commonest age group to be affected are between 30 and 50 years, it is also a lymphoma that is common in children. EBV may play a role in classic Hodgkin lymphoma, and for all intents and purposes, EBV plays no role in nodular lymphocyte predominant Hodgkin lymphoma. Having said this, there are very rare examples, and I think I won't go into the rare examples now of ones that are EBV or NLPHL that are EBV positive. Both are right. They have a germinal center B cell origin, but in the classic Hodgkin lymphoma, B cell markers are absent. Or partial and weak, and other than for PAX5, which is the only marker really that we use to establish the B cell lineage, it is usually expressed weakly compared to the background B cells. Whereas in nodular lymphocyte predominant Hodgkin lymphoma, B cell markers are all expressed, and that is again something that we use to distinguish between these two. And immunoglobulin transcription is crippled and inactive in classic Hodgkin lymphoma, again something we use diagnostically, whereas in nodular lymphocyte predominant Hodgkin lymphoma, this is synthesized and expressed. So there are two different diseases, not just from a pathological perspective, but also in terms of the clinical and management. So a classic Hodgkin lymphoma with modern chemotherapy, majority are curable. So they're treated also differently, and they behave differently from nodular lymphocyte predominant Hodgkin lymphoma, which is indolent and is characterized by relapses, but are only rarely fatal. So they are more akin to the way low-grade B-cell lymphomas behave. So in classic Hodgkin lymphoma, it's a painless lymph node mass, and typically it's not rapidly enlarging. And one thing which is very key, clinical is always, in any lymphoma diagnosis, you should always take the whole picture into consideration. It should be an integrated diagnosis. So if there are more than one nodal group is involved, it is a contiguous nodal group that's involved. So you'll have cervical, you'll have axillary, you'll have then the mediastinal. And now inguinal can be involved, but only as part of a chain of nodes, not as isolated lymph node. So mediastinal involvement we know is common, and when it involves the abdomen, it's usually isolated abdominal disease you can get, but it's uncommon. It's always axial. It's usually part of a chain of nodes starting from the thorax and going down. Mesenteric nodes, for instance, would be very rare. Now, in contrast, in NLPHL, you can have isolated lymphadenopathy of very long duration. It can be years sometimes. And these can arise in a background of a benign condition called progressive transformation of germinal centers. I've just put a little image here on the side here of PTGC, and you can actually see it as PTGC may precede, it may follow, and infrequently you may see it in the same node. So patient who has NLPHL in a subsequent biopsy, it's important to biopsy because it may be showing only PTGC. And some imaging doesn't necessarily help because both can be PET active. So sometimes you can get the PTGC and NLPHL in the same follicle. Now, PTGC, we know the enlarged follicle, you have an increase in the IgD positive, the benign IgD positive mantle zone type cells, and they will encroach on the follicle and cause this moth-eaten appearance of these germinal centers. So when they both involve the same follicle, you'll see these moth-eaten, germinal centers that I have and the red dots, which are the NLPHL neoplastic cells. So in terms of the distribution of disease, they are frequently cervical, axillary, less often femoral inguinal. It doesn't have to be contiguous at all. Mediastinal involvement does occur, but it's very rare, and mesenteric nodes can be involved. So you can see distribution of disease is very different. In both conditions, classic Hodgkin lymphoma, most are stage 1 or 2. But in advanced stage disease, you can have splenic involvement and less often marrow and liver involvement. Now, in NLPHL, again, most are low stage 1 or 2, stage 1 or 2. But in about 20%, you can have advanced stage disease with liver, spleen, and again, infrequently bone involvement. So having said this morphologically, let's just look at the differences. So let's look at the neoplastic cell. So the Hodgkin/Reed-Sternberg cell, or Hodgkin-Reed-Sternberg. Hodgkin cell is the mononuclear cell, and the Reed-Sternberg is the typical, the binucleate Auli nuclei or the multinucleate cell. So if you look at this, and if the lymphoma that you've got in front of you has actually read the textbook, this is what it would look like. And you have these cherry red nucleoli, perinucleolar clearing, these large, so this is a binucleate or bilobate form, and abundant cytoplasm. This is a mononuclear form, and this one has a lacune, which you typically see in the nodular sclerosis subtype. You may also see mummified cells. The background in this case can be a mixed inflammatory background, like you're seeing here below, or it can be a lymphocyte-rich background in the lymphocyte-rich subtype. But even when there's lymphocyte-rich background, the T cells in the background, which should form the rosettes, are not strong PD-1 positive, as we will see in the NLPHL. So if PD-1 is positive, it's moderate to weak. Now, the LP cell, on the other hand, looks like as if it's like a very distorted and blown up centroblast almost. It has this popcorn looking nuclei, and hence the term popcorn. It's like sort of bubbling chromatin and smaller nucleoli. And the background is either lymphocyte rich or mixed with some histiocytes. And the rosettes, as I've shown you, are strongly positive for PD-1 because they are T follicular helper cells. Now, having said this, although they are different in the typical sense, when you get a core biopsy, some of the cells, which may be an NLPHL, can have central cherry red nucleoli, and you might see smaller nucleoli in classic Hodgkin lymphoma. So on histology alone, sometimes it is not possible to tell them apart. So you need immunohistochemistry, and that is quite very useful. Or you put everything together, of course, the morphology and the clinical and the immunohistochemistry. So classic Hodgkin lymphoma, you have you have the subtypes, nodular sclerosis subtypes. So this kind of architecture also will help you in making your diagnosis. If you see the typical history and typical age group, typical distribution and nodular sclerosis. So this, even on an H&E, you can sort of come up with the diagnosis. More common in resource-rich areas, 80% mediastinal involvement. The lymphocyte-rich is your tricky one, and this is one which you will need immuno often to distinguish between NLPHL. The mixed cellularity one is more common in the developing world in HIV patients, and these are frequently EBV positive. In the Western populations, always exclude other differentials such as nodal T follicular helper cell lymphoma, and we'll see that in a minute, and the angiomoduloplastic type, which can have cells, honestly, which look like textbook Reed-Sternberg cells. The lymphocyte depleted is often a misdiagnosis, and in the past, I think there were a lot of these diagnosed which were actually non-Hodgkin lymphomas, either B cell or T cell, which were misdiagnosed as Hodgkin. Now, immunohistochemically, these can be easily, the two can be told apart. So in classic Hodgkin lymphoma, it's CD30 positive, strongly and diffusely. CD15 in most cases are positive. Sometimes it can be only focally positive. CD20 is variably positive. Its strong positivity is very unusual. So it's always, it's either negative, or in about 30% you can have a weak variable positivity. CD79 is negative. PAX5, as I said previously, will be positive but weak, which tells us that it's a B cell lineage. CD45 is difficult to interpret because there are so many CD45 positive cells in the background, but these neoplastic cells should be CD45 negative. EBV may be positive or negative, and the immunoglobulins, all of them should be negative, and even the transcription factors like OCT2 and BOB1 will be negative. Sometimes one of these may be expressed, but never both. On the other hand, in nodular lymphocyte predominant Hodgkin lymphoma, they are CD30 negative. I say that you can get weak CD30 positivity sometimes, but in classic Hodgkin lymphoma, it has to be very strong membrane and Golgi staining. The CD15 is negative in NLPHL. I mean, these are the typical examples. Okay, there will be the odd rare case, but I won't go into that. CD20 is positive, strong. CD79 is positive. It will also be positive for other B cell markers. CD19, CD22, these will be negative in classic Hodgkin lymphoma. PAX5 is strong. CD45 is positive. EBV is negative, and these immunoglobulins, J chain, the joining chain, heavy chains, light chains, they will be positive, and light chains will be restricted. We'll see one example in a minute. And the OCT2 and BOB1 will be positive. And the OCT2 is a very useful nuclear stain which helps us architecturally also to appreciate these even at low power. We'll see this. So the question I'm going to ask you, and I'm not going to wait for an answer, but I'll give it, is for you to think about, if you see a cell which looks like a Hodgkin Reed-Sternberg cell in a biopsy, does this equate to classic Hodgkin lymphoma? And the answer is no. And the diagnosis requires not only the HRS cells, but you have to see the appropriate inflammatory background. And sometimes in difficult cases, you'll have to really correlate well with the clinical and radiological findings. And if necessary, you might have to resort to genetics, especially if the material is scant and you don't have that much information maybe. But in most cases, you can actually make the diagnosis without resorting to genetics. This is very important. So as I said previously, your diagnosis of lymphoma should always be an integrated. If something doesn't fit, if the clinical doesn't fit with the histology or one of these doesn't fit, always question yourself whether it could be a mimic. So these are examples of entities that have HRS-like cells but are not classic Hodgkin lymphoma. And if I show you this Reed-Sternberg cell in the top left here, you will say this is a textbook Reed-Sternberg cell, but the cells surrounding these are a little atypical, and actually they are expressing CD10, which is an aberrant expression. It's seen in about 60% of the angiomoduloplastic type. And actually, if you look around, you will see the background cells, which are these almost these pale clear cells of medium atypical cells, clusters, you will see them. But not always, because sometimes, like in this example, it's not that easy to spot which the neoplastic cells are, although you're seeing this increase in high endothelial venules. The background, unfortunately, is a mixed inflammatory background, which is very similar in both entities. So if it's a typical case, you will see this florid FDC expansion encircling the vessels in the angiomoduloplastic type. So the issue really is because the neoplastic cells may not be that obvious, and the HRS cells, they are often EBV positive in angiomoduloplastic type, but they may be negative, you see. So that doesn't always help you. But the important thing is if it is positive, and we'll see examples of this, EBV positivity is seen in a range of cells. Some of these will look like immunoblasts and not just the Hodgkin Reed-Sternberg-like cells. Again, I emphasize clinical, IHC, and genetics, and sometimes you might need clonality and mutational analysis to help you to make this distinction. It's another example of a condition which has HRS-like cells but is not classic Hodgkin lymphoma, and that is infectious mononucleosis. Now, this is a terrible mistake to make, and the problem is that both can present in young patients, and sometimes they say the pitfall of infectious mononucleosis is biopsy, because if they a wrong diagnosis is made, this patient will be overtreated, and we've had examples of these who have nearly been overtreated because of misdiagnosis. But if you put everything together, you shouldn't make a mistake. So although you see cells which look like this, if you look at the background, there will be cells. These will have B cells which look like immunoblasts, almost look like very large plasma cells. There's a range of spectrum of these immunoblast plasma cells, large plasma blast-like cells, and immunoblasts. And if you look at the EBV, you can see the variation in size of these cells, and the background, shouldn't usually see eosinophils. So they will also be CD30 positive, these cells, and EBV will be positive, but as I said, it's in these smaller cells as well. The clinical is really key because these are tonsillar involvement with generalized lymphadenopathy. So tonsillar location would be very rare and unusual in a classic Hodgkin lymphoma, and that should alert you always, especially in a young patient, for infectious mononucleosis. Oftentimes, by the time you sort of think, take your time to, get the biopsy sorted, the patient is already showing signs of improvement. Another condition where you can get HRS-like cells, but it is not classic Hodgkin lymphoma, is a more recently described EBV-positive mucocutaneous ulcer. So these can sometimes look like diffuse large B-cell lymphoma, but also you can get HRS-type cells. The important thing is if you get a nice section of the ulcer, you will see that this forms this sort of fairly superficial, like a band-like infiltrate of these CD30 positive cells that are EBV positive. These patients have an underlying immune deficiency invariably. So it's important to put everything together. So now, very quickly, I'll talk a little bit about NLPHL. And just to say that, so NLPHL, there are 6 different morphological types that you can see, or patterns, and patterns A and B. So in NLPHL, what you have is you have the large LP cells, you have the background, which are these follicular structures, which have an increase in IgD positive mantle zone type B cells, and you will have the TFH cells, which are also forming the rosette. So it's depending on the percentage and where these components are, the patterns have been created. So classic is when you have the typical pattern that we know about, which have these, it's a B cell rich nodular pattern. If the nodules are interconnected or the follicles are interconnected, this is a serpiginous. So A and B are essentially the typical patterns. And these alternate patterns, like when you have the cells outside the epithelial cells, mostly extrafollicular. If it's T cell rich and nodular, more like a T cell histiocyte rich large B cell lymphoma. So these are C, D, and E. And F is if it's B cell rich, more like a large B cell lymphoma. So these are the alternate, the variant patterns, C, D, E, and F, are more associated with advanced stage disease and a higher relapse rate. So this is, I'm just giving you this image. This is from the WHO Blue Book, and you can actually look at the book and see, have a read of this. So if you look at the follicular structure in LP Hodgkin's, you see these follicles have these holes, and in these holes you have the LP cells, and the LP cells have these rosettes you can see around it within this hole-like structure. And if you look at the OCT2, this is what I was telling you about the OCT2. It's a beautiful stain. You can see these dark big cells, which are the LP cells, and the background, you can see the rosettes, which are negative, which are the T cell rosettes, and then you have this increase in the IgD positive mantle zone type cells, which are benign, the benign part of this. So if you look at the LP cells, these are the LP cells, the popcorn cells, and the background has these mature lymphocytes, which are quite normal looking mature lymphocytes. Contrast this with another neoplasm, which arises within the germinal center, which has a follicular architecture, which is follicular lymphoma. I mean, these don't look that much alike because in follicular lymphoma, these follicles are quite small, but I have had registrars coming to me saying, isn't this not lymphocyte predominant Hodgkin lymphoma if you get these centroblasts? But if you look at the cells around these are centrocytes. So these are not the small mature IgD positive mantle zone type B cells, but these are also the part of the neoplastic cells, so the centrocytes and centroblasts. So we move on to our cases, which are fairly quick, but we'll go through them. This is a young female, left cervical lymphadenopathy, and look at the imaging: cervical, axillary, mediastinal, retroperitoneal, pelvic. So all axial lymph nodes, liver and spleen. So this is disseminated disease, and spleen and liver had focal lesions. So this is an excision biopsy. So looking at this, straight away you can see that there is capsular sclerosis and these sclerotic bands and cellular nodules. So this looks very much like the nodular sclerosis type of classic Hodgkin lymphoma. Let's look at it a little closer. So this has, I mean, we are used to seeing individually scattered HRS-like cells, but this is forming a sheet in most instances. But look at the background. So we'll see more of these, and the background has this sort of eosinophils and neutrophils and some histiocytes as well. So we'll see a little bit more of this. And you can see these cherry red nucleoli in these cells. Some of them are actually quite small, the nucleoli. More of the same, an occasional mummified cell is seen. You can see these plasma cells. Again, the background here doesn't have that many eosinophils. And in this part, there are quite a lot of eosinophils. And here the cells are more individually dispersed. Here, this is the background only really, and you're seeing this mixed inflammatory background. So now you look at the CD30. It's a sheet of CD30 positive cells in the most part. In some areas, it's more clustered with some individually scattered cells. So then we have to think about sheet-like infiltrates of strong and diffuse CD30 positive large atypical cells. What are the possibilities? At this age group, ALK-positive anaplastic large cell lymphoma, because that occurs in young patients. Less commonly, it could be an ALK-negative anaplastic large cell lymphoma. It could be a classic Hodgkin lymphoma, given the distribution of disease and the architecture, syncytial pattern, nodular sclerosis subtype. I just want to say that ALK-positive ALCL, there are some Hodgkin-like patterns where you can have this sclerosis. So you have to be a bit careful about these cases. Primary mediastinal large B-cell lymphoma is not a disease where it's a mediastinal, it involves a mediastinum and supraclavicular node, but it doesn't disseminate in lymph nodes. So that's something that is unlikely in this case. But you have to think about that because, again, you can have sheets of CD30 positive cells and embryonal carcinoma, of course, because of the age group and the mediastinal location. So if you look at anaplastic large cell lymphoma and look at our case on the right, you can see actually if you have a case side by side, this was an ALK-positive example. It looks very different, really. The nuclear features are quite different. So you don't really see these cherry red nucleoli, and you might see some hallmark cells if you're lucky, but, and it has this very cohesive appearance. So these look a little different. This was also CD15 positive, which also is helpful in our case. And they are weakly PAX5 positive. So this is unlikely to be a T-cell lymphoma. It was negative for T-cell markers. And this is CD20 negative. It's a negative for CD79A, CD19, CD22. It's also negative for OCT2 and BOB1. So the full house of markers, except for PAX5, the B-cell markers are negative. So CD23 highlights follicular dendritic cell meshworks, but the other cells themselves are negative. And CD3 is just highlighting some of these are rosetted by T cells. So immunohistochemistry is quite helpful if you can't make the diagnosis on morphology alone. So alloaplastic large cell lymphoma, obviously with ALK positive, it will be negative for PAX5, it will be negative for CD43 and other, it will be PAX5 negative and positive for CD43 and maybe positive for other pan T-cell markers, you see. So that's important. And anaplastic ALK negative will be PAX5 negative and again have a similar distribution of T-cell marker expression. Sometimes, as you know, these can have a null T-cell phenotype. But remember, the PAX5 negativity is quite useful. In the ALK positive cases, of course, you can do the ALK. Classic Hodgkin lymphoma, this is the case, obviously, now you worked out that we have. And mediastinal large B, clinical is important. And 60% of these cases are CD23 positive, and of course, it will express all the B-cell markers. Embryonal carcinoma will obviously be positive for A1, A3. So further markers that we use in classic Hodgkin lymphoma, MUM1 and P53, they are just sensitive markers. They're not specific by any means. And the CD45 in this case, because it's syncytial, you can work out that that's negative. As you can see, there are so many CD45 positive background inflammatory cells that it makes it difficult sometimes to interpret. Facin is a marker that is not universally available, but this is a marker that is positive and it helps you to differentiate these from large B-cell lymphomas. EBV in this case was negative. We use EBA in situ hybridization. So this is classic Hodgkin lymphoma, nodular sclerosis subtype with a syncytial pattern, and this is EBV negative. The next case is a 56-year-old male. So now this is an old age group. This is a prominent low right cervical lymph node. There's a left paratracheal and anterior mediastinal prevascular nodes. So you can see now there's a chain of nodes and there's smallish nodes. Submitted is a mediastinal lymph node co-biopsy. So now you can see what I mean by a co-biopsy. If you didn't have any of the history, you could really, although looking at it, you might tell me these have very cherry red nucleoli. So this is likely to be classic Hodgkin lymphoma. I can tell you that there are examples of NLPHL that have these kind of nuclear features sometimes. And on a co-biopsy, it becomes difficult to tell them apart. But given the distribution of disease, you have to think also that this may turn out to be a classic Hodgkin lymphoma. But let's see. So architecturally, there's a vague nodularity to this. It's difficult to appreciate this maybe. And they're individually scattered, mostly mononuclear cell, large eosinophilic nucleoli, and background rich in small lymphocytes. There are no eosinophils inside. So the differential diagnosis should be classic Hodgkin lymphoma, and on histology alone, nodal lymphocyte predominant Hodgkin lymphoma. So again, now we'll apply our immunohistochemical panel. So CD30 is strongly positive in these cases. So now that is a marker moving towards our classic Hodgkin lymphoma. CD15 is positive in a proportion of cases. CD3 is for just highlighting the rosettes, and there's some incrustation a little bit. And sometimes, occasionally, you can get Hodgkin lymphoma expressing T cell markers aberrantly, but most of these are like encrusted on the surface. PAX5, you can see there's PAX5 positivity, and it's weaker than the background. Okay, it's negative for CD20, CD79A, OCT2, BOB1, and also IgD. So now remember, the background in these follicular structures is the small B cells that you see are IgD positive. So the background B cells don't really help you very much. CD21 is highlighting a follicular structure here. But what you see, if you're lucky to see a germinal center, unlike in the moth-eaten PTGC, this will be a well-demarcated eccentric germinal center, and you'll see in the expanded mantle zone, you'll see these neoplastic cells. So these are the CD23. Again, you're seeing the holes, and you're seeing the large cells within the holes. So that seeing the holes within the FDC meshworks is not a feature that will help you. So P53 and MUM1 are positive again, and MUM1 is also positive in the T cell rosettes, by the way. So, but that doesn't really, it's just a sensitive marker. That's it. If it was not positive for MUM1, I'm thinking, okay, what could it be? Something else. So this is positive for, sorry, just bear me a second. This is positive for Facin, you can see here, and it's negative for EBA by in situ hybridization. So this is classic Hodgkin lymphoma, lymphocyte-rich subtype, and this is EBV negative. So this is another example. Now we go on to a 7-year-old female, enlarged right cervical lymph node, and this is probably a stage 1, and this is an excision biopsy of a right cervical lymph node. So this doesn't tell us very much as to what it could be. So you are seeing a lymph node. Unfortunately, this is the, and you can see the periphery of the node seems fixed in a slightly different way to the center. But you can see there's a nodularity here. There seems to be something which is lighter, and there are darker areas as well. Let's go a little closer and try to have a look. So you're seeing this, there are some small mature lymphocytes there. Let's take a closer look. So you're seeing these small lymphocytes, and you're seeing these larger cells. So now some of these you can see there's a cherry red nucleolus here with perinuclear clearing. Some of these look more like the LP cells with a smaller nucleoli and look like blown up centroblast nuclei. Most of these, in fact, look like that. But you are seeing some cases with these prominent central nucleoli or large nucleoli at least. But a lot of them look like this blown up central, the popcorn appearance. And the background has small mature lymphocytes, but it also has some histiocytes. So these are some other areas which have fewer histiocytes and are mostly lymphocyte rich. So again, we'll now apply our immunohistochemistry. So now look at this is interesting because look at the CD30. So again, one of the things, especially in lymphoma diagnosis, it's not just important to look at what is positive, but also look at what is negative. So if you focus only on what is positive, you might fool yourself and trick yourself into thinking these are the atypical cells. But if you look at these are just activated lymphocytes that are CD30 positive compared to these large giant cells, which are actually negative. So the neoplastic cells are CD30 negative. What is positive in the background are activated lymphocytes, which could be T cells in this instance. So now look at the CD20 on low power. You can see that some of these may be connecting up, but they seem to be separate follicular structures for the most part. And you can see here the large cells are strongly CD20 positive. There's a rosetting of cells which are negative for CD20, and then there is this population of smaller CD20 positive cells. CD3 is highlighting the rosettes, and you can see this here, and quite a lot of background T cells as well. And again, you're seeing the structures with the holes on the CD23 stain. and that cells themselves are negative for CD23. So OCT2, as I said, is very useful. Even at low power, you can sort of appreciate the follicular architecture, but at medium power, you can see the background small lymphocytes and these large cells, which are surrounded by cells which are negative for PAX5. So in other words, T cell rosettes, you can see very nicely. And actually, OCT2 is a very useful stain to do if you have access to it. So now kappa and lambda, I know that a lot of laboratories don't necessarily have this, but this is more for education to know that these are light chain restricted and expressing light chains. So if you look at the large cells, they are kappa positive and lambda negative. But there are lambda positive cells here, as are kappa positives, much more kappa positive cells here, which are the smaller cells. So the smaller cells are polytypic for light chains. So those are those IgD positive cells, which are positive for polytypic and so not benign cells, as opposed to the neoplastic large ones, which are kappa restricted. PD1 is, you can see lots of PD1 positivity, and you can see this is why some people might get confused with the TFH lymphoma. And I'm just putting this, I'm not spending time on this. Try to have a look at the WHO. This is from the table in the new blue book to tell you how to differentiate between these. So one of the things is that in the angioblastic type, the atypical cells, if you're lucky, if they're CD10 positive, you'll see FDC meshworks, and you'll see this range of B cells, not just the HRS or the LP cells or whatever the cells are. So that is, in this case, we are looking at NLPHL, so although they look like HRS-like cells, this is the differential, obviously, because of the PD1 positivity creating this confusion. Previously, we didn't used to do PD1, so I think this was, this really has more recently come into the differential, but clinically, they're so different because oftentimes these NLPHL is something that is a more indolent clinical course, and, it's a very different clinical presentation, but if you're really stuck, you can obviously rely on clonality and genetics. So diagnosis in this case is nodular lymphocyte predominant Hodgkin lymphoma, FAN pattern A/B, but ultimately it's a typical pattern. And if you're using the ICC terminology, nodular lymphocyte predominant B-cell lymphoma. So next case is a 76-year-old male right cervical lymph node enlargement, excision biopsy of the right cervical node. So this lymph node, there is a big nodularity to this. And there is some sclerosis as well, but they are not forming any bands. There's a mild thickening of the capsule. And going slightly higher, you can see that there are these individually scattered large cells with multilobated nuclei in a background of small lymphocytes. And here again, more of these. And you can see here, these are multilobated. You can see one large nucleolus, but the other nuclei are fairly small. So most of these are more akin to popcorn cells or LP cells than the classic Hodgkin lymphoma. And the background is lymphocyte rich. So if there's a lymphocyte rich background, the differentials really are mostly these two entities of whether is it lymphocyte rich classic Hodgkin lymphoma or is it NLPHL. So looking at this, you can see the FDC meshworks. They are sort of interconnecting FDC meshworks. You can see these holes again with the large cells and the rosettes. And again, looking at CD30, although there are CD30 positive cells, these large cells are CD30 negative. And CD3 is highlighting the rosettes, and it's quite rich in T cells in the background. You can see that. And the B cells on the low power, you can see these interconnecting the smaller, these are the IgD positive mantle zone type B cells are coming up with the CD20, and you can see these sort of connecting up the follicular structure. So looking at it on a medium power, you can appreciate both the large cells and the small B cells in the background. And here, some areas, again, here you're seeing the same. This is CD79A, which is positive in both components, the large cells and the background small B cells. OCT2, again, is useful. And IgD here, you can see, is highlighting the background small B cells, but not the large cells. So there are a subset of NLPHL, particularly the state pattern D, the ones with extrafollicular localization of the LP cells, which are IgD positive, but these are not IgD positive. It's the background cells that are IgD positive. And you get the number of PD1 positive cells. So this is why sometimes it can be confusing with a TFH lymphoma. And these are positive for all TFH markers, bar the CD10, which is an aberrant sort of expression. It's seen in normally only in a very small subset of T cells, but it can be seen up to 60% of TFH lymphomas. It should be negative in NLPHL typically. So ICOS and CXCL13, but of course will be expressed because these are expressed in most TFH cells. So this is NLPHL, and again, this is fan pattern B, and it's a typical pattern. So this is, if you use ICC terminology, this is nodule lymphocyte predominant B-cell lymphoma. Our last case is a 36-year-old male. This is a young male, lymphadenopathy query cause. Now when you get this sort of case where significant weight loss, massive splenomegaly, widespread lymphadenopathy, this becomes a little more difficult clinically because there seems to be an aggressiveness to this. So what is this? So this is a core biopsy from a left cervical neck node. And this has a pink appearance as opposed to all the blue biopsies that we've seen so far. And the reason why it's pink is because there are a lot of histiocytes in addition to small lymphocytes in this background. So now let's look at it a little closer. And in addition to the histiocytes, which you're seeing here, you can see scattered large cells with very prominent nucleoli here. And so you're seeing more of these here. This one is a little blurred, but you're seeing a histiocyte-rich and a lymphocyte-rich background. And more of the same. And there's occasional FDC meshworks on the CD21, but nothing to write home about. And the CD30 is negative in the large cells. When you can see them, you can see them here. They're negative. Don't mistake the histiocytes, of course, which also have large nuclei, but you can see the nuclear details even though there is no eosin. And on the CD20, you can see, and the 79A, strong positivity in these large cells. So we know we are not dealing with the classic Hodgkin lymphoma, at least, yes? And because of the marker profile, okay, CD30 negative and CD20 and 79A positive. There seem to be a few smaller cells that are also positive, but there are very few of these. And on the PAX5, you can see the large cells, but you're also seeing some scattered smaller cells. OCT2 is showing these large cells and a few small cells as well. IgD, there are these occasional cells which are coming up with the IgD. And so there are some mantle zone type cells, but very few of them. CD3 is negative, but you can in the large cells, but there are shed loads of T cells in the background. And as you can see, even though they are PD1 strongly positive. So they are TFH cells. So don't now think the trap that you can fall into is that this is a TFH lymphoma at this point. If you see this and you do ICOS and it's positive, and you do CXCL13, it's positive. So then you think, am I dealing with a T cell lymphoma? So this can be quite difficult. So now the diagnosis in this case is not lymphocyte predominant Hodgkin. If you have problems, you can do clonality and you wouldn't get a T cell clone in this case, okay? But this is not lymphocyte predominant Hodgkin lymphoma, and this is fan pattern E. This is a variant pattern. And so this is the differential really is with T cell histiocyte-rich large B-cell lymphoma. So it may be actually impossible, and this is what the WHO says as well, on a core biopsy to make this difference. But one thing that I can tell you, my experience has been in all cases that have been diagnosed previously as a T cell histiocyte-rich large B-cell lymphoma, if the patient lives and then relapses, they often relapse to show us that this was actually originally a variant pattern of not lymphocyte predominant Hodgkin lymphoma, because the relapse shows more typical features. So the favoring NLPHL in this case is the abundance of PD1 positive T cells forming rosettes, the residual IgD positive mantle zone type small B cells, and the partially preserved FTC meshwork. So these are sort of clues. But the WHO requires for fan pattern E that other areas of the biopsy must contain one or more other patterns to be classified as NLPHL. So I think on the basis of this, in a core biopsy, maybe you could say the favored diagnosis is this, yes, and say the differentials are with T cell histiocyte-rich large B-cell lymphoma, and tells why you favor this. So now I'll just conclude to say that classic Hodgkin lymphoma and not lymphocyte predominant Hodgkin lymphoma, or the ICC terminology, not lymphocyte predominant B-cell lymphoma, are completely separate disease entities. They have different the clinical pathological features, different immunohistochemical features, but importantly, prognostic and treatment options offered to the patients are very different. So HRS HRS type cells alone are not sufficient to diagnose classic Hodgkin lymphoma. It requires the appropriate inflammatory background. And the differential diagnosis will depend on the subtype of classic Hodgkin lymphoma. So, for instance, the lymphocyte-rich subtype and NLPHL can be morphologically very similar, and actually you should use immunohistochemistry to tell them apart. Immunoprofile of the two are very different, so that's very helpful. And the fan pattern E of NLPHL, or nodule lymphocyte predominant B-cell lymphoma, has a T-cell and histiocyte-rich background and actually can mimic a T-cell histiocyte-rich large B-cell lymphoma. And it may be impossible on a core biopsy to tell these apart. And with this, I will end, and I hope I haven't provided you with an information overload, and I will stop sharing the screen. Are there any questions or anything that I could?
Well, thank you very much for that excellent run through. I've spent many years looking at Hodgkin and its mimics, and I must say that was the best presentation I've had of sorting those out. The last case, you said that it would be impossible, virtually impossible to distinguish on a core biopsy. What do you think of the value of CD21 for the follicular dendritic cell networks in those cases?
So I find that quite useful. The fact that if there are FDC meshworks, particularly if there are small B cells associated with it, honestly, personally, I try not to make the diagnosis of T-cell histiocyte-rich large B-cell lymphoma, and except in the spleen where you get this micronodular T-cell histiocyte-rich large B-cell lymphoma, I would really I don't make the diagnosis very easily. I would say that I would definitely favor this very strongly because, when you see the PD1 positive cells, for instance, all those features, they're soft features maybe, but, I think the entity of T-cell histiocyte-rich large B-cell lymphoma is poorly characterized because there have been so many cases of LP Hodgkin, the pattern E, fan pattern E, which have been included in this. The only thing to remember also is that although we make this distinction, these patients are treated as if they were a large B-cell lymphoma because they, previously in the previous iteration of the WHO, this was referred to as T-cell histiocyte-rich large B-cell lymphoma. T-cell histiocyte-rich large B-cell lymphoma-like pattern of nodular lymphocyte predominant Hodgkin lymphoma.
Okay.
Which was what pan pattern E was called. And they called it a transformation.
Okay, so they would be treated as a high grade anyway.
Yeah, they were treated like that. And I think still clinicians, because of the extent of disease and the aggressiveness, they generally treat these patients with R-CHOP anyway. So I think treatment-wise, but it's interesting that these patients will survive then, and then when they relapse as LP Hodgkin. So, you look quite silly that you've made the diagnosis of this. There are a lot of pathologists who actually question, although the WHO still recognizes the entity T-cell histiocyte-rich large B-cell lymphoma. It's interesting to see how this, in the future iterations of the WHO, where this goes.
Yeah. I think over the course of my career, I've made, I like yourself, I've made that diagnosis less and less as time's gone on. I think it may be in the 90s and early 2000s, it was not a terribly uncommon diagnosis, and now it's becoming a lot rarer.
Yeah, I mean, I remember the first case that I saw. I mean, we didn't even realize this connection. And there was a case I was working with Professor Isaacson, and it was diagnosed as T-cell histiocyte-rich large B-cell lymphoma. And then the relapse had positivity and IgD. It was an IgD positive case, and that was an interesting thing. But so at the time, it was difficult to make the connection because it hadn't been made.
Yeah. And PAX5, I find PAX5 a useful marker because in the classical, you've always got a nice internal control, and yet the Hodgkin cells are nicely weak by comparison. Do you find the same?
Absolutely. And also it's very useful when it comes to differentiating from T-cell lymphoma also, because sometimes, that is, so PAX5 is really, if I have a case which is PAX5 negative, I am really scared to. I had a case, and I don't have I can show it to you, a mediastinal mass in a patient who was an older patient, mind you, and it was a PAX5 negative, CD30 positive, and it was very crushed. And I was tempted to say, looks like Hodgkin, but I can't make the diagnosis, get another biopsy. But I did, because it was PAX5 negative, I did an ALK, and this was an ALK positive anaplastic large cell lymphoma in an elderly patient in the mediastinum. So, you get these odd things. So I think it's very important to cover all bases when you can.
So that is
from having another biopsy.
So in your experience, will there almost always be some weak PAX5 positivity in the classical
In
Hodgkin's.
most cases, I mean, I think if it isn't there, I would be very concerned. And in that case, it was
Yeah.
CD2 positive and CD2 and CD2 was positive, but CD3 was negative. You see this positive ALCL. So the CD3 didn't have.
Yeah.
No, we tend to do 3 and
Yeah.
20. We don't do all the markers all the time. We
I
tend to
know.
anti-tissue
Yeah.
particularly. Yes. Yeah.
Yeah. Are there any questions from the audience? I think you've kind of stunned them into silence. I mean, it was so. Like I said, this will be uploaded. People will be able to access it through the pathology portal. A really excellent coverage of cases. I'll just see if there's any questions. Otherwise, I'll let you go to the rest of your busy day. And thank you very much again for your
Thank you.
time
Thank you.
and that excellent set of cases.